Go.
Good morning. It's beautiful in Blue Ridge, Georgia today. You know, BKP was talking about the fact that it was fall as of 9 p.m. last night.
9 p.m.
And I had come out here this morning in this tie.
You got your Santa
you
tie
got your
on.
Santa Claus tie already.
All right.
You're early,
Now
man.
this is going to
this
is
one.
going to take a minute. Jane and I don't do Santa Claus and stuff. We don't believe in it. We do a Christian Christmas. So I went into Costco to buy something really important, like the coffee, which is cheaper, the other day, and they have all of the Christmas stuff out, and I was sort of semi-offended by that. The same day, the president said that the COVID epidemic was over, and then he said that the inflation had gone up an inch, and it just began to pile up on me how much we are sort of led by advertising and people speaking. And then I was in a nice black jacket when I was sitting here, and then he talked about fall. Well, on purpose, you know that the costume of the khaki pants starts in the spring and ends in the fall, so it's like 9 o'clock last night. I should have switched to the black pants. It was my plan to switch to the black pants on Monday when I go to the office. So it'll be black pants between all the whole winter now, the rest of this show. Just like the women can't wear white shoes and the glove things in the church. Remember when we did that? There are no white shoes after.
What the hell's that got to
and
do with
there's
that
gin
tie?
and tonic in the summer and bourbon in the winter, and it's just all
Well, I'm
that's
sitting
how it
here
is.
staring at Santa Claus and a snowman.
Yeah. Well, I know that. That's because I'm offended. I don't wear this tie.
No, you were semi-offended.
Semi-offended I was.
Yeah.
So I'm still trying to catch on here. You wore it just to be offended today?
No, I have to tell people how I don't like the fact that people try to drive what we're doing by subtle advertising.
I want to say something about 9 o'clock.
9 o'clock, okay.
My bride went to her belated 2-year late 50th high school reunion last night.
Oh, you're in so much trouble.
I just stepped on it there, didn't I? Anyway, south of Cincinnati, all the power went down in the plane. All the TVs went off, all the lights went off, and the pilot came on and said, "We're having to divert this flight. We have an emergency."
Ooh.
And they had a very rough landing with fire equipment and all kinds of stuff on the runway, so it was serious. Anyway, she sat in Cincinnati for many, many hours, so they got another plane to take her on up to Minneapolis after midnight. Anyway, my wife had a scary night last night.
She missed her. She wasn't.
No, she'll be there.
It's tonight.
It's tonight. Yeah.
She wasn't
She was
okay.
upset.
Well,
So
no, she was
glad
grateful
she is
for the
safe.
safe landing. All right.
Yes.
You know, you came out this morning, you asked me if I needed a jacket.
I did.
You got any earmuffs in there? I take earmuffs.
I've got a ski, one of those things you wear down
I
like
take
this.
almost the whole cap right now. One of them hunting caps with the
Well,
red.
Elmer Fudd hats?
I take one
Yeah,
of
but
those.
if you hadn't had your hair cut so high, you had your ears lowered, and then
He's going full Elon Musk this
it
morning.
uncovered your ears, and then they got cold.
I got in trouble by my mom even. She's like, you needed your hair
You got too
trimmed.
much hair cut off.
Well, you know what? I grew up in a region where your hat had flaps.
Yeah, Pennsylvania, that's right.
Okay.
You
All right,
remember,
moving right
we
along.
all had to wear hats. Okay, we have
It's
got
time for Ask the Doc. This would be Dr. William Whaley, by the way, and Dr. Raymond Tidman.
And who's the sponsor?
many thanks to Georgia cancer specialists affiliated with the Northside Hospital Cancer Institute.
Exactly.
Now, I'm going to tell you that these questions this morning are, interestingly enough, both of these questions are genetic questions. Most of the answers deal with genetics. And you'll remember 6 years ago or so when we started this program, I said that in the future we will be treating cancers based upon their genetics rather than saying it's breast cancer, colon cancer, or ovary cancer, even though that's where it started. The driving force to the treatment will be what the genes show.
Did you think it would get this advanced this fast?
No, I did not. I thought it was advancing fast, and I said so. But this is really a huge, some of the stuff that's happening right here, within the last 6 months you've seen evolve. So this is this first question, and this is a question. We try to keep things simple. I'm not going to teach you how to build a watch quite yet, but when people talk about cancer, they have a mental image of something. Then there are these describers. Wildfire cancer, we think of acute leukemia and small cell lung cancer, but we're getting ready to talk about a wildfire growing cancer today that we generally think of as being relatively slow in progression, and we've talked about it many times about prevention and diagnosis. Okay, my brother is 50 years old and has never been sick and does not go to doctors. Now, we've heard that a million times up here. For 6 months, he has had swelling in his neck and jaw that are lymph nodes. Now, I bet you somebody along the line probably treated him with antibiotics. It does not say so.
Probably a couple times.
Maybe. He saw an oncologist who ordered a biopsy and labs, including lymphoma labs. That's normal, lymph nodes. They were normal, and before he could have the biopsy, 2 days after his visit with the oncologist, he went in the hospital with hip pain and was found to have a pathological hip fracture. And he had not had any pain before. So he's got a broken leg 2 days after he walked into a doctor's office without pain. That's a huge difference.
Let me
Go ahead.
Let me digress just for a second. So, a patient with lymphadenopathy who's otherwise been healthy, it would be normal to observe that for several months and treat it with a round of antibiotics if he has symptoms. But so that it's a perfectly normal course of therapy. You don't send every lymph node in the office off to get a biopsy.
Yeah, please don't.
So
that was all appropriate.
Yeah.
There's nothing been missed here. It's
right.
just that it's changing really fast right in front of your eyes. He had surgery. So at surgery, they removed the hip, and he was diagnosed with malignant melanoma, meaning that was found in the hip, broken hip. It was present. So they did a scan then in his chest, abdomen, and lymph nodes everywhere. Now here's the really important speed thing here. A brain MRI was normal. He was hospitalized for 4 weeks, and due to rapid progression, so before their very eyes, these lymph nodes were getting bigger. He was apparently losing weight. I don't know, he didn't say that, but they said this is progressing so rapidly that before we get him out of here with this hip fracture and whatever else was going on, we have to start something. So he was begun on 2 pills, wasn't chemo, called anti-BRAF pills. He was not eligible for the Jimmy Carter immunotherapy drugs as an inpatient. Now that is one of those insurance. Medicare guideline things, but unfortunately that's the way it is.
Insurance malpractice.
Well, they act slowly too. So I mean, they act so slowly that there's generally never any reason that you are urgently going to have to give them in the hospital, and that's the background behind it. But anyway, that's what happened to it. At discharge 2 days ago, this question came in on Tuesday, so he was discharged on Sunday. A repeat brain scan was done because he was dizzy. Now, he just had one 3.5 weeks before. And he has developed several small cancer spots in 3.5 weeks in his brain. Now, that's very unusual. Brain metastases generally just don't pop up. And if you've got a negative MRI, we don't repeat them for 3 months, 4 months, 6 months under normal circumstances.
So, Bill, I mean, this is a very intense case you're presenting here, right? So I keep pausing you here.
No, I want you to.
This man was walking around perfectly normal, perfectly healthy, and then 2 months later, he's got mets in his. 1 month later, he's got mets in his brain, and he's got insurance companies saying, "Well, the rules say this." I mean, this is tragic. I mean, you're talking about people who need to have their act together. This man needs his act together.
Yeah, I'm not going to argue that too badly, because as I say, immunotherapy moves slowly, and that's the reason they got the rules. And what these doctors did was genius, by the way. Mm-hmm. All right. So he's got brain mets. He's going to see his original oncologist who had started with things before the hospitalization. He wants to be treated closer to home. So he's been sent to a cancer center somewhere. Does it sound like it is too late for, now this is the important thing. Does it sound like it's too late for him? Or do you think with his brain and rapidly progressing tumors that something meaningful can be done? Now you're looking, you got the right question in your mind, which is.
Go ahead.
Go ahead. No, I'm gonna say.
I want to say first off, I want to ask the question because it starts out the brother is 50 years old, and we have the little running thing that they put on social media when you turn 50. Your check engine light goes on. The little thing they say, but. It has never been sick. It does not go to doctors.
Brian, that's where you get the black tape out and you put over the check engine light. Oh, go ahead. I'm sorry.
Yes. Could this have happened that rapidly?
It's a very unusual
Absolutely,
case.
Yes. The guy could be going to the doctors all the time, and this would never have been prevented.
So if you're going to the doctor, I don't like to hear. Well, this is a very deep question that's got a lot that you're going to go through. But I don't even like to hear when somebody says I'm 50 and I've never been sick and I don't go to doctors. I just say kindly, that's not good. You go to the doctor. You go.
But
to the
if
doctor.
he had, I really don't think it would have made a difference.
That's what I'm sitting here thinking.
Because this is not colon cancer that a colonoscopy would have done.
Exactly.
And sure, you don't do a colonoscopy until you're 50. And now he has malignant melanoma, but we don't hear that this is the type where you don't have a mole anywhere.
Yeah, right. There's no mention of him having a mole.
No.
What I'm saying is nothing I'm seeing here falls under the age test. When you're this age, we want you to have this test.
Should have had a mammogram.
Right.
Okay. That's perfect. Because our next question we're going to have is going to come up into some of that in a minute, but not this question. All right. But the question really is this going so fast that the quality of his life would be diminished by treating him and dragging out his death? And should we let him have morphine and ice cream and let the Lord call him home? Or is there a reasonable chance that intervention right now might benefit him? That's what the question is, correct?
Yeah.
And the question really is, does it sound too late for him? Or do you think with his brain and rapidly progressing tumors, this is the key, that something meaningful can be done? So this question was well written.
Right.
Put up the first one. You've seen this one a million times. How many times we talk about melanoma?
Exactly.
Okay, what you're talking about is he goes to see Ray, he's got one of these things, they find it, they biopsy it. Pull that down there. We're always talking about melanoma in a slow progression. This melanoma may well have been a spot on his body that went away without ever being seen. That's called where a spot disappears. It's an unusual behavior, but we often see melanoma like this that's diagnosed because there's a spot on the lung or somewhere else, and there's nothing on the body anywhere. So whatever was on the body was insignificant and disappeared, or it's just not much there. Okay, push this back up. The next. These drugs that he began were called anti-BRAF pills. You got that up there? Now this is really important. We have talked here about lung cancer in the past and the targets that they go look for in lung cancer that guide what we do for them. BRAF is one of those markers on a lung cancer. Colon cancer, KRAS, NRAS, and BRAF, we've talked about all the time. You're not supposed to remember that, but the RAS and the RAF and the Bs and the Ks, you're supposed to just have that in your head, that in colon cancer, if you've got one of these things, this set of drugs is helpful for you. And if lung cancer, if you've got it, that same two drugs don't help you. So it's two different types of malignancy that the presence or absence of BRAF drives whether or not a specific type of intervention is beneficial for that particular type of cancer. Pull that down now, because we're going to be talking about another gene in question 2 that has nothing to do with BRAF, but it's a gene that's going to be driving lots of other types of malignancies. Now put this next question up. This is Ray's favorite picture of this guy in the sun, putting on his sunscreen and all of that stuff. Now pull that down. The purpose of that is that we talk about sunscreen and staying out of the sun and don't get sunburned and blistered 4 or 5 times before the age of 14. But the reason for that is people who have a BRAF gene that then get exposed to sun that acts as a cancer promoter are more likely to end up with melanoma. Now, you got that off the screen now? You'll remember I said that tobacco, cigarettes, don't have a cancer-causing chemical in it until the lining of your lung enzyme activates or operates on one of these ingredients in smoke that makes it promote cancer. We talked about colon cancer and fiber and Dr. Burkett a few weeks ago, and the things in your diet that can cause you to have bladder cancer or colon cancer require you to have an enzyme that operates on the wax or the insecticide that makes it become malignant. Now put the next one up here. This is a colon cancer slide about BRAF. Now you remember when we were talking before about right-sided cancers are so much more aggressive than left-sided cancers and all of that business? Well, that you get in here to the molecular features and the genetics, you can pull that down, of cancers of one side of the colon or the other side of the colon are all wrapped around this gene, this BRAF gene, that these drugs they gave this guy are for. Now, we're still talking about genes and stuff that operate against genes. So put the next one up. I'm not going to make you read everything, but that says triple therapy for BRAF mutated colorectal cancer.
Right.
So this, every time we talk about the BRAF, we don't talk about it in melanoma. We talk about it in colon and occasionally talk about it in melanoma. You can pull that down a minute, but it talks about triple therapy, meaning they're attacking this cancer from about 3 different directions with 3 different genetic products in patients who have colorectal cancer. So put this next one up. There are at least 70 or more different BRAF genetic mutations. And this part over here on the right, where it says 1%, 0.9%, 59%, 23%, and down here where it says V600, A, B, D, E, and all the rest of that stuff, pull it back down. Frequency of occurrence of the different mutations. So every one of these BRAF mutations aren't the same. So you got this BRAF gene that's got about 600 places it can be manipulated, and that is what has driven this particular patient to have the biological behavior that he has. Are you still with me? All right, put this next one up, and we're going to get off of this big-time science and get back onto this poor patient here. Mechanisms of acquired
resistance to BRAF.
There you go. All right. This is the issue of multimodality treatments that go after the same gene. Now I know you can tell about, you see all that's all genes getting messed up by one thing or then another, right? Put it down now, because I'm going to come back to that again in a minute. So, what they are doing in that triple therapy with the colorectal cancer is they're giving a BRAF modifying drug. It's not going to be the drug given to this guy, because this guy's drugs were studied in melanoma and not in colon cancer. But they have drugs that are exactly the same, like the difference between chocolate, vanilla, and strawberry, that were studied in colon cancer. So there's the same type of drug, but it's not available for melanoma because that's not where it was studied and it wasn't released for that purpose. I mean, Ray understands what I'm saying. So put this next one up. Ray and I, you got it up there? All right, Ray and I can be at the marina over here in the summertime and see a guy with his shirt off who's got a big old bump like that on his chest, and we will tell him from across the room, you've either got a lymphoma underneath your skin or you've got some other something that shouldn't be there. Pull that down. Now, as he said, if these nodes were in the neck, and they were, he'd at least tell him, go see your local doctor. He would have given him the antibiotics, but it puts me back to remembering that hockey guy with the woman saw the thing on the back of his neck. This sort of thing we can see from across the room. So for a few months, this guy had that. Put up the next one. Without warning, 2 days after he's walked in the doctor's office, he had what you see on this picture, which is a bone that snapped because cancer is all growing in the bone. Now that's it after it's fixed, they put a rod in there. Pull that down. We're going to just briefly look at this a minute because it's going to tell us, you got it up there? This is going to tell you why this guy who is progressing so fast that they had to do something within a few days in the hospital or he was going to die, why it's reasonable to do something for him rather than giving him morphine and ice cream. This is a very simple graphic, isn't it?
Yeah, it looks simple.
Yeah, right. It ain't the least bit simple. But this is the genetics of what makes a cancer be wildfire growing. So this particular melanoma has some of this BRAF stuff going on here. Pull that down, I know it's complicated. But why are so many melanomas slow growing and you want to get it biopsied and get it removed? And then if you don't, it's diagnosed 3 years later, we try to get the lymph nodes out. It hasn't done this. It's stayed local. It's because of all of these different genetic things that can be happening to that one gene in this one poor guy. Now put that next one up. Here are the two drugs this guy got, cleverly named Braftovi and Mektovi. Now what they did was this Braf drug is going to hit this tumor. It's got to be dividing fast because he had nothing in his brain 3 weeks ago and now he's got something in his brain. And then this one is the one that works against the things that would make it become resistant on that thing back there. Pull it down now. Does that make sense to you? All right. We have said before that if you have pneumonia that's rapidly progressive and you are going to die in 24 hours, it doesn't make any difference how fast you give the antibiotics because they won't have time to reverse the process and you're going to die. Now, acute leukemia, when we were children, 100% of them died in 6 weeks to 12 weeks, regardless of whether they sent them anywhere or not, because they didn't have any drugs. When Ray and I were in school, that could treat the majority of kids with leukemia. Now, 80% of them run down to Emory or Children's Healthcare, they lose their hair, and they're cured because that disease divides so fast that when you attack it with drugs that are effective, the more rapidly it divides, the more effective it can become quickly. Does that make sense?
You've got targeted therapies that are very good for that disease now. But go ahead and wrap. I'm curious about. I keep coming back to the questions that are sitting out there in the public. Is what was going on with this man's neck? Was that a red herring? Was that just something that? Okay.
No. That was one of the lymph nodes.
Okay.
That was that.
So the fine needle biopsy missed the melanoma.
Huh?
The fine needle biopsy missed the melanoma.
No. They did a lymphoma blood panel.
No, I'm talking about this man had malignant melanoma.
But he didn't get the needle biopsy up here. He didn't get a needle
he didn't
biopsy.
Get to that.
He came in the doctor for one visit, and they ordered a biopsy.
So he hadn't gotten it yet.
And they ordered a lymphoma panel in his blood, and it was normal.
Okay, so he never got the fine needle.
As a matter of fact, he's normal like this, except for these tumors.
Yeah.
All right, so put up the next one. Here's your PET scan or your nuclear scan, and this is this guy. Everywhere in his body there's a black spot, right? This is a patient who had that much malignant melanoma and took those 2 drugs, and this picture is made 12 weeks later. Those spots are gone. Pull that down. Now, the question then is it reasonable to treat my brother? And the answer to that question is yes. 2, was there a mistake made, or was it an insurance company mess up that he didn't get those other 2 drugs? And the answer is no, because they work slowly. These drugs work rapidly. And if your brother is going to have that response, you're going to know that before Thanksgiving, or maybe even, yes, you'll know it before Halloween. Halloween's in 4 weeks, right? You'll know that before Halloween, because he'll be dead before 4 weeks at the progress he's going if this drug does not work. Now, once these drugs work and you've beat it back with this type of therapy, you will continue this treatment until relapse or until toxicity, which may never occur. These drugs may keep him going for weeks or months or years. We don't know. They've only been available for about the last 4 months. But the drugs, the Jimmy Carter drugs that they didn't give him in the hospital because they're slow working, are sitting right here waiting for your brother if he relapses. And they are extremely good drugs. So he actually has a better outlook with this rapidly growing cancer of this type than many people with slow growing tumors of another type. So even though it's dramatic, let them treat him and be encouraged that this progress in genetics has occurred within the last several years, but this has occurred in the last 6 months. There.
So one real quick observation here. I want to pull this out of you because I think you and I agree on this. In this situation, you're saying the insurance company did not harm him.
No.
But you would also say, had his 2 doctors said he needs to get the Jimmy Carter drug, you'd want him to get that drug.
Oh, yeah, right.
You would want them to be able to overrule that insurance company and their protocol.
Yeah, you would. And then you'd go through, well, here's what would happen now, because you and I do this. As a matter of fact, we've got a whole department that does this. I think we have 6 different people who just deal with insurance companies before it gets to peer-to-peer.
Yeah.
But the opportunity, and I think I told you about that one where Dr. Bernstein was operating with this company, and everybody from the medical director to the president of the company said that give him the medicine. But the contract that the employer had written with the insurance company specifically prohibited paying for it. So I'm going to make this observation because it's the way of life. If you have purchased $1,000 deductible insurance on your car and a tree falls on it and it's $990 bill, regardless of the fact that it was God's will and it was the weather and everything else, nobody's going to pay for that $1,000 repair on your car or $995 repair on the car because you got $1,000 deductible insurance, period. So the insurance company's not at fault there. And to argue about the insurance company not allowing something to happen when that policy has been written in such a fashion that it violates the policy, if they violate it one time and they got 10,000 employees, then they're going to have to violate it thousands of times. So that's just the way life is. It's not nice, and I don't like it.
All right.
You don't thank Georgia Cancer, right?
That's what I was about to do. I just, I just think every one of these questions, I think about the families and I think about the rooms they're sitting in when they're talking to doctors and getting updates.
You've been there,
like that. Yeah. So I when somebody types out and says, "Does it sound like it's too late?" What?
Well, you asked me that question when your mother had
Yes,
B
yes.
cell lymphoma and was slipping down the tube so badly. And what I told you was, kick ass and take names. The treatment's going to make her sick, and she has a chance of being cured. How many years ago was that?
We should be coming up on the 3rd year of a PET scan. We have over 2 years now.
Okay, and she had a disease that was going to take her life in 8 weeks.
Absolutely.
Or 6 weeks.
Absolutely.
She would not have lasted 6 weeks, right?
Absolutely. I understand.
All right,
I understand.
all right, so you have a great sensitivity for this.
Yes, I do, and I appreciate your answers. And I often think when we get these questions about both of you, your profession, sitting in a room with families and talking to them. So I got a lot of respect for what you do.
Plus, she's tough from the region of steel mills, so I mean I think that helped too. So.
What?
Your mom,
Yes.
Pennsylvania.
I have my own question today.
Oh, you
Yeah.
do? Okay.
Yeah, I have. There's a third question. I have one.
Okay,
we're
is that
ready to
about
get going
your
here.
haircut so short?
No.
I just do want to thank your barber for giving you such a wicked, funny-looking haircut.
All right, let's go to work. You want to
Georgia
do that?
Cancer Specialist, Northside Hospital Cancer Institute. Thank you very much. Question number 2.
My